Maybe Millie, I'll ask you in terms of Ustekinumab. Or first of all, I'll ask, do you have any concerns about clots with Ustekinumab? And you already mentioned the oral contraceptive, but are you prophylactically anticoagulating your patients on tofacitinib? So kind of a variety of questions. Ustekinumab and clots, any worry? And if you were to use tofa, do you actually anticoagulate them?
So I don't actually anticoagulate them, except in incredibly rare circumstances, someone traveling internationally, which isn't happening during COVID when they have a high inflammatory burden. So what I do instead is I look at risk factors we discuss. I think it's really the IBD can drive this too, remember, just the severe colonic inflammation alone. We have a discussion about it and I move forward. If a woman is on an oral contraceptive, I definitively change that on TOFA. And the other issue is, remember that smoking increases your risk of clotting as well. And so a smoker would not be a great candidate for TOFA in my mind either. But no, I don't prophylactically anticoagulate.
Great. And then Dave, as we transition to the questions, COVID, would you treat her differently with COVID in the era of COVID? And if she did get COVID and she was on Ustekinumab and say she's due a week later, what do you do with the Ustekinumab?
Well, the consensus statement in the absence of prior evidence had said that you should hold immunotherapy until the patient recovers from their COVID illness. And that was in the era or the early time when we didn't know whether this might make the infection worse. So if you want to stick to what is currently published, I would say you hold the therapy for the next 10 days, or according to the IO-IBD recommendations, and they worked with infectious diseases experts, at least 3 days after symptoms have resolved. And then you resume and you reset the clock on the intervals for follow-up of the therapy. What has emerged has been the idea that maybe you keep them on therapy. Now, this particular patient is so high risk, as you've heard us all discuss, that we may actually want to just leave her on the treatment that's working, recognizing that the anti-cytokine therapies seem to have either no negative impact on COVID or may even have preferred lower risk outcomes. So hopefully this will be moot as people are getting vaccinated. But in my practice, I would probably hold it for at least a week while I see how bad the COVID's getting and letting the patient recover overall. Remember, the half-life of the drug is such that it's going to be there anyway. Some of this is kind of an academic conversation, but I think the prudent, conservative, sort of down the middle of the road choice is to hold it and see what happens over the next week and then get her back on therapy.
Great. And I do the same thing. If it's a patient that's very severe with their IBD and we've started on an anti-cytokine therapy, although the guidance is to hold the therapy, I am not doing that. And I do exactly what you do, Dave. And then if the patient's doing well, as you said, I always try 3 days from the fever, 10 days from the diagnosis of COVID, if we can, but we have to also be careful, especially with drugs that are immunogenic, that we don't do that. Ustekinumab and Vedo may be not as much of a concern as the other anti-TNF agents. So wonderful discussion. We're going to transition to the questions now. Millie, there are a lot of TOFA questions, and I think probably this comes out because of some of the recent evidence on safety. And maybe I'll actually have you start by just giving a recap of some of the recent safety updates or guidance. But then also, and actually I'm going to ask all three of you this question. We can decide also if we switch to some of the others, but there was a great question on what kind of patient is your number one non-study, so in your real practice scenario, best utility, glad we have TOFA. So what's your kind of first line? But start with the safety of TOFA, the recent updates, and then when would you use TOFA first line?
Sure. So as I mentioned, this is kind of hot off the press. So I think we had some questions about clotting knows about the original about a year ago communication from the FDA saying that there was increased clotting risk in this one RA study, 1138, in patients with cardiovascular risk factors who were actually on higher dose tofacitinib maintenance, which is not the approved dose in RA, but the 10 milligrams twice daily maintenance. And so we've known about this warning in that population. We have not seen increased clotting in UC populations, but that's why it's positioned post-TNF. Well, more recently, more of a readout came out on that 1138 study. Again, rheumatoid arthritis patients who have cardiovascular risk factors. And this was a non-inferiority study. So there are a lot of knots and like confusing language surrounding what the results were. But essentially, their confidence intervals when they read out this study of TOFA group, whether they were on 10 or 5 twice daily, as compared to the TNF group. And the TNF group was either on etanercept, which is used in RA, or on adalimumab. They found that the confidence interval was such that they couldn't say there was non-inferiority for 2 outcomes, one being malignancy and the other being cardiovascular complications. And so the FDA came out with a warning for this drug class, saying that we need to consider that there may be increased risk, cardiovascular risks, and increased risks of malignancy. And interestingly, when you drill down in the data, and I cannot explain this, it seemed to be lung cancer that kind of came out as the cancer malignancy. And so more data, more understanding of that study needs to be done. And remember, that's not in a UC population, and that we have not seen that necessarily in UC patients. And so I think we just need to use this as a counseling when we're discussing it with patients, that this may be the case. But again, that study was older patients with cardiovascular risk factors, which is not, at least for me, the majority of the patients whom I care for with ulcerative colitis. In my mind, I still use TOFA in my practice. I think it is a highly effective agent. In my mind, it is a very good agent for these young, hot UC patients who you've tried a TNF and they have not responded, or that maybe they initially respond and then lost response. I have seen it heal up dramatically significant inflammation and really turn a patient around from that colectomy trajectory. And so I think for those people who are worried about inflammatory burden, more on the severe side of UC, this is a great post-TNF option with appropriate risk counseling.
Great. So just to make one point, and then I'll get to the other 2 as well, and you can comment on what Millie said, but I'm going to ask each of you a question also. Just to recap what Millie said, the data on safety has been specific to rheumatoid arthritis, more on the patients who are over the age of 50. And I think we need to use this as guidance, but as you, Millie, have used TOFA, it has worked extremely well in our sick ulcerative colitic patients. We can get into dosing maybe if we have time in a minute, but nonetheless, it's something that works very well. The label does indicate after anti-TNF failure. So first line is somewhat limited by the label, but I can have the others comment if they ever use it first line. And it's something that, again, we should not inhibit our use of TOFA in ulcerative colitis because of the safety data in RA. Vinci, I'm going to ask you a quick question about Vedo, but you can also talk about TOFA, and then Dave about Usta, and you can also talk about TOFA or Vedo. But Vinci, there are some questions on when would you use Vedo in IBD? Let's expand it to beyond Crohn's, just Crohn's ulcerative colitis. When would you use Vedo first line, and when is the subcutaneous dose going to be approved?
Yeah.
I know, I'm waiting for that too, or at least our patients are. So Vedolizumab first line, I think, if you can recap of my talk, in general, ulcerative colitis patients with mostly moderate disease, not the ones that are severe, about to go into the hospital or worried about colectomy, would be the ideal candidate in the UC patient population. In Crohn's disease, I typically use Vedolizumab first line for my Crohn's colitis patients. I have this affinity for using Vedolizumab in my inflammatory colon patients. I typically don't use it as first line for my fistulizing, or severe, severe about to be hospitalized, either UC or Crohn's patients. Now we have great data, at least from comparing Vedo to adalimumab from our varsity trial. So I think that's like our first ever head-to-head in being able to look at one mechanism action to another. Now, the only problem with that is we're only looking at one anti-TNF, not the other anti-TNFs, and one, the IV, that, you know, I would like to see, you know, that comparison too. But ideally, going back to that, answering that question, the ideal patient would be the moderate and the, you know, not the severe side, the moderate scale, the moderate to severe patients with UC, and it doesn't matter if it's, you know, proctitis left side or pancolitis, and the Crohn's patient with mostly colonic disease is the ideal patient I would use as first line. And of course, the other thing would be if they don't have any comorbidities, such as, let's say, rheumatoid arthritis, lots of extraintestinal manifestations, or psoriasis, where you may need to use another agent that will take care of both, you know, the both comorbidities at the same time, because, you know, vedolizumab is more specific, gut specific.
Great. And Dave, I'll let you comment on anything, but there's a question about ustekinumab and fistula. So your experience and the data on ustekinumab and fistula. And then after Dave's question, I'm going to do fast round robin to see how many of these questions we can get through. And I'm going to challenge each of you to keep it to about 20-second answers. So Dave, I'll let you speak for a little bit now, and then we'll go through the quick round robin.
Well, I'll be focused. With any therapy with Crohn's, we always want to know about perianal disease. And up until more recently, our pharmaceutical colleagues have not wanted to pursue perianal as an indication, other than what we've done years ago with infliximab. I will tell you that one of the novel targeted small molecules that's in development is actually tackling perianal disease. With ustekinumab, what you do is then look back at the pivotal trials and ask the question, how many of those Crohn's patients who got into the trial also had perianal disease, and what happened to them? And as we saw with Vedo, when they did the same analysis with ustekinumab, of the small number of patients who had perianal disease and were enrolled in the clinical trials with ustekinumab, about a third of them had improvement of their perianal disease, and it was better than placebo in a post-hoc analysis. So there is some benefit. The main message, I think, across all therapies and for Crohn's and ulcerative colitis is whatever you're using, make sure it gets where you need to go. And you've heard a couple of our colleagues endorse repeat scoping, and now we've talked a little bit about MRI imaging of the pelvis and whether that might be helpful as well. So that's the point. Regarding what Millie said about TOFA, I completely agree with her. I will drive home the point that it's not just about saying this is rheumatoid arthritis in which these patients had these, the small number of complications that were worse than TNF. In ulcerative colitis, we have more than 6 years of follow-up on TOFA, and there has not been a signal of major cardiovascular events. There has not been a signal of pulmonary emboli or other venous thromboembolic complications, and there has not been malignancies. So it doesn't mean that we don't think about it, and it certainly doesn't mean that we don't continue to monitor our patients and go through this. But a targeted small molecule, when it's necessary, is a very nice and different pharmacodynamic mechanism of action for patients, and we shouldn't leave it off the table. And if you're not comfortable using it or you haven't used it, then please talk to your colleagues and work with them to give your patients that option.
So just to recap, ustekinumab has been in a retrospective or retroactive looked at for fistula, and there are some evidence that it works in fistula, and I've seen that in my practice as well. And the tofacitinib safety in ulcerative colitis, and Dave, I'm glad you brought up the long-term extension, looks safe in ulcerative colitis. So while it's not to disregard the rheumatoid arthritis safety, I think we need to be practical in our own patients. All right, now we're going to do quick questions, quick answers. So Millie, I'll start with you. Do you give Shingrix to your young patients, and specifically in those starting TOFA?
I offer it. And I advise them that there can be costs associated with it and tell them what those will be. It is covered for everyone 50 and over, but not always in younger individuals.
So yes, you try, you let them know about the cost. And then, sorry, Bincy, I'm gonna ask you a question. Any data on hemorrhagic stroke that you know of with TOFA?
Not that I know of for TOFA, and at least not in the IBD or the UC study population, no.
Yeah, so that was an easy one to answer because the answer is no. So hemorrhagic stroke, again, would not be something we would expect with TOFA.
I've seen hemorrhagic stroke and IBD related to venous sinus thrombosis in the brain. So from the overwhelming active colitis and clot. So it's a hemorrhagic conversion of a venous thrombosis that leads to that. It's a devastating complication. I had a pediatric gastroenterologist call me about a young patient who just had that in his practice. So that's related to the clotting of the disease. It wasn't related to therapy.
Yeah, so to Dave's point, I've actually had a few patients with sagittal vein thrombosis and venous thrombosis. If you have a patient with new onset headache, especially that's significant, don't ignore that and think beyond the arterial system, because it's like a DVT. It's just occurring in a different location. So thank you, Dave. Dave, when do you start the vaccine? So you have a patient, you're starting on tofa. To Millie's point, you try to get the vaccine. Do you have to wait for the first vaccine? Do you have to wait for both Shingrix vaccines? How do you do that?
No, I start them on therapy, and I usually give them the Shingrix vaccine after they've already started to respond to the treatment. The rate of herpes zoster occurs after you've been on the drug a little bit longer. So it's a low incidence during the induction phase anyway. And so we just get everything going as quickly as we can. Just in reference to the question about paying for it, we stock it in our clinic. So we've been able to give it to patients, and I haven't seen it bounce back from insurance when we've done it.
Right.
When we send patients to the pharmacy, I now actually have my team print out the special populations comments in the CDC website about vaccination against shingles, which includes immune compromised patients, which technically is our IBD population, and have them show that to the pharmacist. When patients have had to pay for it out of pocket at a pharmacy, just so you know, it's a couple $100.
$200 each.
I think it's a worth, yes, thank you. I think it's a worthwhile investment, but I know not everyone can afford that, obviously.
And to reiterate that, I've had the same experience. We stock it in our clinic, and when it's bundled under their visit, I have not had patients have issues with the cost. It's the sending them to a pharmacy that is a little bit more difficult.
Yeah, just a separate comment, maybe more to Miguel's expertise, is that providing those in your clinic isn't just a good thing to do, but it's a revenue stream.
Correct. And yeah, so we can get into the technical revenue, and we now have a pharmacist who works with us who's a superstar, and we're starting to give more and more vaccines in our own clinic. And I think that that's important. Bincy, there's a question here about a UC case. I'm just going to summarize it. This is an ulcerative colitis patient who's been on azathioprine, prednisolone, Vedo. Every time the patient tapers below 10 of prednisone, they actually have a UC flare. So this is an ulcerative colitis patient, younger, refusing anti-TNF because the mother had multiple sclerosis. Interestingly, there's another question on MS in a minute. But they've had a venous thrombosis in the upper extremity. Does a venous thrombosis in the setting of active ulcerative colitis preclude the use of TOFA? And then also ask, does a multiple sclerosis family history preclude the use of an anti-TNF? So hard questions, but what do you say?
So someone who's not necessarily not completely improved on Vedolizumab because they're still steroid dependent. First thing I would do is, of course, assess the disease activity. Is it still severe? Have they had actual improvement, endoscopically from when they started Vedolizumab? And the other thing I always do is check their Vedolizumab levels. I aim for, doing maintenance at about a level of 20 or higher. And if they haven't achieved that, I have many of my patients doing fantastic, moving them to every 4-week infusions. So that may actually allow for the patient to stay on the same drug, get them more of their dosing in, and hopefully get them to be able to get off steroids completely. However, if we tried that and it didn't work, then the next option, what I would choose for this patient with the other concerns would be Ustekinumab. Because the concern about the DVT and what was the other one?
The multiple sclerosis.
Multiple sclerosis, right?
Yeah,
so, yeah, it doesn't necessarily preclude the use of anti-TNFs if there's family history. So same thing with the lymphoma. However, I would be cautious because these immune-mediated diseases tend to run in families. So of course, we can discuss things that we would say from the data and what we expect from outcomes. However, patients have this concern, right? And like you said, with your case, Miguel, we recommended the anti-TNFs, but of course, the patient's really concerned. So it's still an option. It doesn't necessarily preclude it per se, but if we were to start the patient on it, then we have to, follow closely. If they end up developing any neurological symptoms, assess them pretty quickly. However, since we have other options, we don't necessarily need to go to that as second line right away. And then with the TOFA question regarding the upper extremity DVT, again, with our IBD, the UC data, we haven't seen that increased risk. Of course, patients may be concerned and there could be a potential that could happen. However, I strongly believe that having active inflammation is what triggers those thromboembolic events in our patients, because we know that's a known risk factor. We haven't figured out if tofacitinib is the true risk factors in our patients. So it doesn't preclude it, but we probably use it as the third line or fourth line if we can use a safer agent. We have that in our armamentarium.
So favoring ustekinumab first. Actually, Bincio is great. I'll let you talk a little longer because you just eliminated about 4 questions. So Dave and Millie, I'm going to bounce back and forth. I'm going to bounce back and forth between the two of you. Dave, if a patient has numerous pseudopolyps, would you consider biologic or send to colectomy? I guess the harder question is what happens if you pick up dysplasia, but do pseudopolyps alone influence your choice of biologic versus surgery?
Post-inflammatory pseudopolyps represent prior inflammation that's healed. The challenge is doing adequate surveillance in such patients. We used to say when you can't see enough and you do some non-targeted random biopsies in those regions, you also have to advise the patient that we can't do adequate surveillance. But I've never met a patient who wanted to have half their colon removed when that's the case. So it's important to know your limitations of what you're trying to do, but it doesn't influence my choice of therapy. It's a representation of healed bowel. It may represent something that happened in the past. It's an interesting question, actually. I've never looked at response to therapy based on the presence of post-inflammatory pseudopolyps.
So Millie, I'll let you, it looks like you're about to say something, but then
I was just going to add one pearl to that, which is remember that when they have an exudative cap, those pseudopolyps, you can see an elevated fecal cal, but that doesn't necessarily mean it's inflammation. And
right.
So I've seen that many times in my practice.
Completely agree, and that's the false positive, but yeah. I'm trying to think about post-inflammatory, the pseudopolyps, where if you biopsy them and look under the microscope, even your pathologist will think it's just the flat mucosa. It looks identical, quiescent colitis, versus inflammatory polyps where you have that exudative cap and there's still inflammation in the polyp, where you biopsy that and it looks like acute colitis, but the surrounding mucosa is healed. So distinction, and then of course there's the polypoid dysplasia. So there's all these different variations in this, and I think as a field we haven't done as good a job understanding this.
So you've given Millie and I a good idea for AIBD in December. We should talk about different types of polyps.
I've got a whole talk on it.
All right. We have 2 minutes left at most. Millie, do you hold Estrella before a delivery?
Hold. I'm sorry, I just didn't hear.
Estrella, Estrella.
I don't know the answer to that. Is it a brand name? I'm probably just not familiar with the brand name.
We'll come back to that.
I'll look it up.
Dave Rubin, do you ever start sub-Q ustekinumab at 4 weeks after induction rather than 8 weeks?
We've actually published a series in CGH I would refer folks to of over 500 Usta patients with Crohn's. And the people who did best with dose escalation were those who had already responded nicely to it. So I wouldn't jump to Q4 when they're primary non-responders. In our experience with that, we haven't picked up very many patients at all. So it would be later, like they respond, they're doing okay, but they're not quite where you want them, or they remitted, they were in remission and they lost response, and then you want to try to recapture. So that's where you do that. And I think that the Stardust study, which was the treat to target study with ustekinumab in Crohn's that used endoscopy as the target, educated us that we don't get that much by doing dose escalation, unfortunately.